Okay. Again, I'm Tammy Frank with the Nebraska Medical Association. I'd like to welcome you all to the sixth in the series of Foster Healthy Weight and Youth webinars that will focus on the psychosocial effects of obesity in children. We'd first like to thank Dr. Carla Lester with Teach a Kid to Fish and the NMA's Childhood Obesity Prevention Project, Holly Dingman with the Department of Health and Human Services Nutrition and Physical Activity for Health program, Dr. Christina Fernandez with Creighton University, Children's Physicians, Dr. Sally O'Neill, Jeff Klein, and the staff at Creighton University CME, and Dr. Tim Nelson with the University of Nebraska for all the work they've done to make this webinar possible. I'd like to introduce Dr. Carla Lester, who will talk about the CME credits associated with this webinar, and will give the background of the Foster Healthy Weight and Youth model. Dr. Lester is a pediatrician here in Lincoln that started a nonprofit organization called Teach a Kid to Fish. Its mission is to prevent and reduce childhood obesity by empowering Lincoln children and families to eat healthy and be active. Dr. Lester also developed the NMA's Childhood Obesity Prevention Project. Dr. Lester?
Hi, thank you everyone for joining us today. I just want to remind you of a little bit of business, and that's that the Creighton University School of Medicine designates this live and enduring material activity for a maximum of 1 AMA PRA Category 1 credit for physicians, nurses, and dietitians. And a detailed information sheet containing this information accompanied this webinar registration and may be found on the Creighton website. After the webinar, you will be sent a link to the post-test and evaluation via email, and you may also visit cme.creighton.edu for more information. Neither the planning committee or speakers for the webinar series have any conflicts of interest or disclosures and have signed statements claiming as such. And then we'll just go over a little bit about Foster Healthy Weight and Youth, which is Nebraska's clinical childhood obesity model. The resources have been and continue to be disseminated to physicians across the state. It's a comprehensive model with a toolkit, pocket reference algorithm, free CME training videos, and outlining the steps in assessment, prevention, and treatment in the primary care setting. There are also consistent messaging, patient brochures, and posters to resource your office. The objectives of the Foster Healthy Weight and Youth webinar series are to explain and illustrate childhood obesity comorbidities, to describe and illustrate assessment of comorbidities in the primary care setting, and to describe and illustrate treatment of comorbidities in the primary care setting. And with that, we're really excited to have Dr. Tim Nelson talking with us today. Our speaker is Dr. Tim Nelson. Dr. Nelson received his PhD in clinical child psychology from the University of Kansas in 2008. He completed his predoctoral internship at Cincinnati Children's Hospital Medical Center and postdoctoral fellowship at the Stanford University School of Medicine. He is currently an assistant professor in the clinical psychology training program at the University of Nebraska-Lincoln. His research and clinical work has focused on children's health issues with an emphasis on promoting the development of healthy behaviors. And with that, we'll hand it over to Dr. Nelson. Thank you.
Thanks, Carla. I'm really excited to be able to give this presentation today, and I just want to say I really think this is an important issue, and I've been really impressed in talking with Dr. Lester about her interest in this issue and her passion for this issue, not only for the medical side of things, but also her appreciation for the behavioral and psychological issues that are associated with it as well. And I'm happy just to contribute to that with this presentation today. Here's a quick overview of my presentation. And first, I'm going to quickly review some key statistics about pediatric obesity, recognizing that many of you already are familiar with these rather concerning numbers. Then I'll talk about the psychosocial correlates of pediatric obesity, as well as the social and environmental causes of this condition. From there, I'll move on to discussing key components of evidence-based psychosocial treatments for pediatric obesity, and I'll conclude with some thoughts about the future of pediatric weight management. This will necessarily be a broad overview. Much of the material that I'll present today is drawn from a 4-hour seminar that I gave recently, but I promise I will condense that and try to keep us limited to the lunch hour here. Okay. Here's a quick overview of some key statistics related to this issue, just to give us some context. First, we see very high overall rates of pediatric obesity. About 17% of children and adolescents are categorized as obese, and that's that category at or above the 95th percentile for BMI. And actually, when we combine the clinical weight categories of overweight and obese, we see about a third of all U.S. youth have a clinical weight problem. So this is a very common issue. We also see that it is an issue that is changing over time and becoming even more of a problem. Pediatric obesity rates have skyrocketed in recent decades. And just looking back at since the 1970s, we've seen about a 370% increase in the rates of pediatric obesity among 6 to 11-year-olds. But the issue is not limited to school-age children or older children and adolescents. We even see this trend of rapidly increasing prevalence among very young children, and we see about 178% increase over that same time frame with children just ages 2 to 5 years old. So really this is an issue that affects youth of all ages, and overall this increase parallels increases that we see with the adult obesity rate. And overall our population is getting heavier, and we are getting heavier at younger and younger ages, and this presents any number of problems. We know that pediatric obesity is associated with a variety of short-term and long-term physical health problems, and I know that those have been reviewed in a previous webinar, and so I won't talk about those. But recent research also suggests some really important psychosocial risks, and those are the ones that I want to focus on. The first area that's received a considerable amount of research is health-related quality of life, and this refers to the degree to which a condition affects a child's day-to-day functioning and the impairment that it causes day-to-day. Research has consistently found that overweight and obese youth have poorer health-related quality of life than children who are at a healthy weight. And actually, some research has shown that the health-related quality of life for these kids is more similar to youth who have cancer than kids who are healthy. And so really we can see that obesity affects children on a day-to-day practical level. Another area of psychosocial impact that kind of makes sense is the impact of obesity on self-concept and self-efficacy. And there's a considerable amount of research in this area, and this is really intuitive, that it suggests that children who are overweight and obese often have problems with self-concept and self-efficacy. They generally don't feel as good about themselves and don't feel that they are as capable as their peers who are of normal weight. Another area that comes up often when we talk about the psychosocial correlates of obesity is depression. And here we actually see mixed evidence in the research as to whether obesity is a risk factor for depression. Some epidemiological studies have found that in the general population, overweight youth actually have similar rates of depression to healthy weight children. That is, they're not really at any increased risk simply by being overweight. However, when we look at kids who come in for treatment for obesity, the kids who are often at the extreme weight and are suffering enough impairment to seek treatment, we often see very high rates of depression within that population. And actually, one study found that among adolescents who were seeking treatment for obesity, about a third of them met criteria for the clinical diagnosis of major depressive disorder. So really we have this kind of conflicting or mixed evidence where there may not be an increased risk in the general population, but the kids that we see that come in for treatment who are often quite overweight, we often do see depression as a problem, and it's something that providers should certainly be aware of. Finally, there is a significant body of research that examines the social functioning of youth who are overweight or obese. First, we see that overweight kids are often viewed more negatively than their normal weight peers and have lower popularity or fewer friendships. And often these kids are the targets of pretty intense victimization. Sometimes that victimization and teasing is the general kind of teasing, you're stupid kinds of taunts. However, more recently, researchers have started to focus on a specific form of teasing called weight-related criticism. And as the name would suggest, this is a form of victimization where kids are specifically teased about their body or about their weight. And research suggests that this can be a particularly harmful form of victimization in terms of the psychosocial functioning of these kids. And actually a study that I did recently with some colleagues at the University of Kansas found that kids who were teased about their weight were more likely to be dissatisfied about their body size, even after we controlled for their actual BMI. And that we found that this effect was actually only there for weight-related criticism. It wasn't an effect that we saw for general kinds of teasing and victimization. And so the effect can be very specific. And the result of this is higher rates of body dissatisfaction, which can be really concerning because it not only affects self-concept and overall clinical issues like depression, but we also know that body dissatisfaction can be a risk factor for poor response to behavioral treatments for obesity. So these social issues, popularity, and friendships, and teasing, all can create risk for long-term problems and even poor response to treatment. Overall, we see that certainly not all kids who are overweight have these psychosocial difficulties, but the difficulties that I've talked about are prevalent enough that medical and behavioral providers really have to be aware of them, and we have to consider these issues in treatment. So we know that pediatric obesity is both prevalent and potentially harmful, both from a medical and psychosocial perspective. But what causes obesity? This is obviously an important issue as we think about treatment. We want to know kind of the core issues that we need to tackle. At the simplest level, obesity is about a chronic energy imbalance. And as we can see from this diagram from the CDC, we have calories in or energy in the form of food intake and also beverages that are consumed. And we need to pay attention to those beverages. Sugar-sweetened beverages can really be a part of the energy equation. And then on the other side of the scale, we have the energy out. And that's through physical activity or through body metabolism. And when these two are roughly in balance, weight is generally maintained. However, obesity results when there is an imbalance where more energy is taken in than energy that's expended. And when this imbalance is chronic and severe, we see weight gain over time, and ultimately we see obesity. This is a really simple concept. And because it is so simple, it is one that is incredibly useful in working with families as we try to think about how child behavior or family behavior can affect child weight. And this is a really simple and helpful way of thinking about that. Research clearly shows that at the societal level, we are messing up both sides of this equation. We are tipping the scale both through increased energy intake, but also through decreasing energy output. And in terms of energy intake, we have dramatically increased the amount of energy that our kids take in over recent decades. One major culprit is the ever-expanding portion size that we see. The average portion size of food in restaurants and for home-prepared meals has increased dramatically. And this has really resulted in a distortion of what we think of as a healthy and normal size. And this goes for food and it goes for drinks. And really we are consuming things that are much bigger portion sizes than we should. In addition to consuming more, we are also consuming the wrong kinds of foods. And there has been an increase in the consumption of high-calorie, low nutritional kinds of foods, also called junk foods, and in sugar-sweetened beverages. So we're taking in more and more of these foods and drinks that are problematic in terms of weight. And then the flip side of it is while we're taking in more bad food, we and our children are consuming fewer of the healthy foods that we really want them to. So healthy fruit and vegetable intake, most kids fall well short of recommendations for the consumption of healthy fruits and vegetables. So we have this combination of increasing energy intake while decreasing energy expenditure, and it's really tipping the scale and resulting in the pediatric obesity problem that we're seeing. In terms of energy output, we have seen a decline in physical activity levels for years now. Most kids don't meet the recommendations for daily physical activity, which is typically about an hour a day of physical activity. Most kids don't get that level, and we've seen decreases over time in the typical physical activity levels for kids. Along these lines, we're also seeing concerning increases in sedentary behaviors. And here we're thinking about screen time, so things like watching TV, time on the computer, video games, can be particularly problematic because the child is really expending a minimum of energy. And so not only are they not being active, but they're not even moving around at all in many cases. And so taken together, the energy increase, in energy intake and the decrease in energy expenditure is really tipping the scale. Here's just a visual to think about the increase in portion sizes that we've seen in recent decades. And here's an example from soda. The bottle that soda is served in has grown over time. And actually, if we went back even earlier to cans and smaller bottles, we'd see an even bigger increase. And 20 ounces or 24 ounces of soda is a very, very large portion. And there's tons of sugar in that, and that's what's considered normal because that's the way it's served. And that is contributing to the obesity epidemic that we're seeing. But simply chalking up obesity to an energy imbalance, although that's accurate, is overly simplistic. And when we think about working with families, we really need to ask a more detailed question. We need to ask, what are the factors that influence energy balance? Because those are the factors that we can potentially work with. And research suggests that a number of social and environmental factors play a significant role. And these are especially important to know because unlike genetic factors, for example, these social or environmental influences may be modifiable and they may be appropriate targets for treatment. So these are things that we really need to focus on and consider in our interventions. First, we have family influences, and these can be considerable. Think about the role of parents in modeling healthy or unhealthy eating behaviors or physical activity. Parents also control portion sizes, and they teach their children what is an appropriate portion size. So some of that portion distortion that we talked about is not only happening in restaurants, but it's also happening at home with parents as well. Parents also have a large role to play in early taste preference shaping. The foods that a child is exposed to early in life can make a big difference later on in whether they're willing to eat their vegetables or if they really want junk food. The early foods that a child gets can really matter. And then finally, parents control what is available to children to eat. And in most cases, kids don't grocery shop. They will generally eat the food that is around. And if that's healthy food and fruits and vegetables and a nice balanced diet, those are the foods that they will eat. However, if there's just junk food in the house, even the child who wants to eat healthier will end up eating those junk foods. So parents really have a lot of control in terms of what is available for the child to eat. But the social and environmental influences are not just limited to the family. And we see important peer influences as well, particularly as children get older and into adolescence. The peer group can be incredibly important in affecting diet, physical activity, and sedentary behaviors. Think about a peer group that is really active and healthy and kind of always on the move versus a peer group that basically sits around and plays video games and eats chips and drinks pop all day. These are very different kinds of influences on a kid, so we always want to be thinking about not only the child that we're working with, but the influences of the peers around that child. They can be incredibly powerful influences. Another social environmental influence that's gained a lot of attention lately is this idea of the built environment. And the built environment is a term that's used to describe the physical layout of the neighborhood in which the child lives. Things like, are there sidewalks to walk on or to ride one's bike? Is the neighborhood safe? Is it safe enough for outside play? Are there grocery stores nearby that carry fresh fruits and vegetables? Those kinds of issues in the built environment can also really affect the behaviors of that child and ultimately obesity risk. So we always want to think about the broader environment around the child. And then finally, we have to consider the role of culture. Culture can be crucial in the families that we work with. In some cultures and in some families, food has an incredibly important role in social interactions. And when we try to eliminate certain unhealthy foods, sometimes we run into challenges that those foods are very important culturally, or they're very important to how that family interacts. So we always have to be mindful of cultural norms and expectations when we're trying to modify these kinds of behaviors, because they can affect the behavior that we see. All of these factors that we've talked about may influence a particular child's obesity risk through energy balance. And effective intervention really requires assessing all of these potential influences and identifying their contributions and making changes where necessary, because these are really kind of the core modifiable influences. So let's take a look at treatment for pediatric obesity, focusing on behavioral and psychosocial approaches. The good news here, as we take a broad look, is that there are some effective evidence-based treatments from a behavioral perspective for pediatric obesity. These treatments tend to be multi-component treatment packages, and many of them can be pretty intensive, which is actually appropriate given what a serious issue this is and how challenging it can be to treat. There are, however, some really important limitations to the research, and we're not there yet in terms of having really great treatments and really kind of full research evidence yet. One important limitation is that the effect sizes that we see for these treatments are often pretty modest. The changes may be clinically important and significant, but we're still generally not seeing effects that work for every kid and make huge changes. So, so really, we still have plenty of room to improve on these treatments. Second, we see much more evidence for the effectiveness of these treatments with children than with adolescents. And in fact, many of these treatments actually don't have any support for their effectiveness with adolescents. Working on adolescent weight problems can be incredibly challenging, and that actually highlights the need for early identification and early intervention. In my personal experience, working with kids on these issues tends to be a lot easier than working with adolescents who are already set in their ways. Certainly we will try to do the best we can with adolescents, but we do have limitations in how effective we can be with that population. And then third, we see a limited amount of research testing the effectiveness of these programs with ethnic minority groups. And this is really an important and concerning issue because there are real health disparities in terms of the rates of pediatric obesity across different ethnic groups. And we need to do more in terms of validating these treatments with different ethnic groups and thinking about how they have to be adapted to provide culturally competent care. And then finally, one of the issues that we just run into, even when the treatments are good, is adherence and dropout. These are often a problem. Most individuals who stay in the program and really work the intervention are going to see some benefit. But unfortunately, many families often drop out, and it's often the families who need it the most, the children who are most overweight or having the most impairment, because their improvement can be slow at times. And so we really need to work to keep them in the program and to keep them sticking with the intervention, because dropout and adherence are real problems. I could go through various brand name treatments that have research support. However, what I think would be most useful for this particular presentation is to look across the different treatments that have research support and talk about some key components that are common across the best treatments. These are really likely to be the core necessary features of effective intervention. And in just a minute, we'll take a look at those core features. It doesn't mean that there aren't other things that can be helpful, but these are ones that are common across the best behavioral treatments. And before we move on, I just want to say it is really important to keep in mind that effective treatment of pediatric obesity usually requires more than just medical monitoring and more than just education. We often have a tendency to think if we can only keep track of them, or if only they understood how serious this is or what they need to do, then they would change their behavior. And unfortunately, this is often wishful thinking. And in real clinical cases, we usually need an extra dimension of behavioral intervention to go beyond just medical monitoring and education in order to support meaningful and lasting change. So here's a list of some of the key components of effective behavioral psychosocial treatment of pediatric obesity. And we'll talk about each of these specifically. We'll talk about diet education and modification, self-monitoring, stimulus control, reinforcement and contingency management, parental involvement and monitoring, increasing physical activity, and reducing sedentary behaviors. And many of these are part of effective treatment packages, but some of them actually even have some evidence on their own. And I think I would recommend all of these be in some way a part of an obesity treatment program in most cases. Overall, these components are designed to work together to shift energy balance. And if the energy balance is such that it's causing obesity, we want to either bring that energy more into balance, or actually even in cases where the child needs to lose weight, we want to shift it so that it creates a negative balance where energy out exceeds energy in. And that's how these core components work. The behavioral and psychosocial treatment component that has the most research evidence and has really been studied the most is diet education and modification. And the most studied program in this area is Len Epstein's Stoplight Diet. And this program breaks foods down into green foods, yellow foods, and red foods. And the green foods are the foods that you can pretty much eat as much as you want. They are the very healthy foods. Typically, vegetables fall into this category. There are also yellow foods that are okay, but we want to just keep track of how much of those are being consumed and limit the consumption of yellow foods. And then there are the red foods, which tend to be the very high calorie, high sugar, high fat, kind of low nutritional value foods. And here we want to limit those foods as much as possible. We wouldn't tell someone they could never have them, but we want to track that and try to limit those foods. And there's a real emphasis on reducing the consumption of high-fat, high-sugar foods, and there's also a focus on those sugar-sweetened beverages that I mentioned earlier. And this diet has considerable support, although much of the research has been really kind of tight research where a lot of the clinical cases that we see are excluded. And so we do need to do more research as to how this generalizes to the kind of clinical cases that come in. But in general, this treatment approach is supported, and I think it can be a really useful way for thinking about and simplifying the diet that a child should be eating, and really keeping things in a way that parents can monitor and support more healthy eating. The second component that I want to talk about is self-monitoring. And self-monitoring is actually one of my favorite behavioral principles because it is so simple, yet it is so powerful. And really the idea behind self-monitoring is that as we track a behavior, as we keep track of it, we actually change the behavior. And we focus this on tracking and monitoring diet and physical activity. So simply by recording what a child eats or by monitoring physical activity, we can actually change the behavior because the family becomes more aware of the behavior and then often will make changes as a result. So the things that we can monitor are broad, but often include those stoplight food categories, so keeping track of the number of red foods as well as the number of green foods and making sure that they're in an optimal balance. So we track fruits and vegetables as well as other concerning kinds of foods. And one important thing to keep in mind when it comes to using self-monitoring is that it usually works best when there is frequent feedback. This is an important issue that's often missed because sometimes providers will just say, keep track of your diet and physical activity. And then the family tracks all of these things and they never get any feedback on it. And that's generally ineffective. What we see that works is when families monitor these behaviors and then get regular feedback. This can be from a therapist, from a physician, from a nurse. It can be in person, it can be through phone call check-ins, or it can be from other group members who are doing the same program. But it's important to combine the monitoring plus the feedback. The next technique that is particularly useful is stimulus control. And this is another one of those behavioral principles that's just really simple and really powerful. And here the idea is that our behavior is at least partially determined by the cues that are in our environment. And often for these kids, there are cues in their environment that are promoting obesogenic behaviors. They're cueing them to eat bad foods or to engage in sedentary behaviors. And often there's insufficient cues for the healthy behaviors, fruits and vegetables and physical activity. And so what we want to do is we want to modify the environment in such a way that decreases the cues for those unhealthy behaviors and increases cues for positive behaviors. So in terms of decreasing the cues for negative behaviors, we might want to limit cues for unhealthy eating. So having a bunch of red foods, the really unhealthy, high-fat, high-sugar foods, having those around and having those out in the open and very visible can be a trigger for actually consuming those foods. So if we take those either out of the home entirely or we put them in less accessible, less prominent places, that changes the cues. And it makes it less likely that the child will engage in those eating behaviors. We can do the same thing with sedentary behaviors, things like watching TV. One of the simple little tricks that I've used at times is unplugging the TV or turning the TV to face the wall. These seem like simple little things, but they give cues that that's not a behavior that we want to engage in a lot. And it creates a little obstacle. Of course, you can just plug in the TV and turn it around, but that's a little bit of work. And often that's just enough to make the child think about the behavior and maybe do something else. So we want to change the cues that are in the environment in order to decrease those unhealthy behaviors. At the same time, we want to increase the cues for positive behaviors. So having fruits and vegetables accessible, having them out or in prominent places where they're seen, they're more likely to be consumed that way. Also, we want to make physical activity items readily accessible and very easy to get to. So instead of having the bike in a place where it's out of sight and it's difficult to get to, having the bike right by the door so that the child can just grab it and go, making physical activity easier is something that actually can really change behavior. Reinforcement and contingency management is another behavioral technique, and this can be important for all ages, but especially for kids. Here we're trying to change contingencies, provide reinforcement for the healthy behaviors that we want to see. Sometimes this can be social praise, just giving a lot of positive feedback when a child engages in healthy behaviors. Sometimes it can take the form of specific behavioral contracts where there are predetermined rewards for the target behaviors that we want to see. I also think it's important to involve the child in choosing those rewards so that they are actually rewarding. They are something that the child is wanting to pursue. One obvious caveat, though, is we don't want to use food as a reward. So the reward for eating your vegetables shouldn't be that you get to have a giant hot fudge sundae. That's obviously kind of giving a conflicting message. But other kinds of rewards can be appropriate, and they can be really powerful in shaping a child's behavior. We also can have rewards from a group when we provide treatment in a group format, where the group really gives a lot of praise and support for appropriate behaviors, and then less support for those unhealthy behaviors that we want to reduce. A key component of any pediatric obesity treatment is going to be parental involvement and modeling of behavior. I have never seen a case that has been successfully treated that didn't involve real parental participation and real buy-in to modeling these kinds of behaviors. And actually some research I was involved with found that in a family-based group program, the best predictor of child weight loss was parent weight loss. The parents model the behaviors, and if they make the changes in the environment and in their own behavior, those lead to child changes. And so we really want to engage the parents here and not make it just about focusing on the child. And then finally, we want to do things to increase physical activity and reduce sedentary behaviors. And some research suggests that reducing sedentary behaviors may be actually more important than increasing real vigorous physical activity. And just cutting down on TV and computer time and video games can actually go a long way to reducing obesity risk or treating obesity. And Epstein recommends no more than 2 hours a day for all these different sedentary behaviors. And so some of the kids we see are spending 5, 6, 7 hours a day watching TV, on the computer, playing video games. And if we can just reduce those behaviors, even if we don't get them involved in really intense physical activity, often that's enough to help shift their energy balance. There are also some strategies that we use for increasing physical activity. We try to identify fun activities. Kids are going to do those things that they enjoy more than the things that they're kind of forced to do. And we also try to do social physical activity where kids exercise with parents or with siblings or with their peers. So it's not just something that they're doing in a solitary way. There are a number of obstacles that must be overcome in many cases. These are not easy things to do, and so we work with families to problem solve around ways to overcome those challenges. And then we have to remember that sometimes, particularly with kids who are very overweight, it may require a gradual buildup of physical activity. They may not be able to handle the intensive, long periods of physical activity in the beginning, and so we really want to promote and reward short bursts of physical activity that are at a lower level, because that's still a step in the right direction. There are a number of other treatments or treatment components that are quite promising and can be a part of effective behavioral interventions. One of the ones that has quite a bit of emerging evidence is motivational interviewing. And this can be kind of a standalone intervention or can be incorporated into comprehensive treatment models. Here we really try to draw discrepancies between values and behavior. We think about stages of change, and we really work on the motivation to change and empowering families to make that change. And this can be started in the first session, and it's great when families are hearing the same message from their medical provider, their behavioral provider, from all different kinds of perspectives. We also do some problem-solving training. There are a lot of obstacles to eating right and to being physically active, and often it takes someone working with the family to make those behaviors a reality, to overcoming those obstacles. And so problem-solving training can be a helpful way. We teach a problem-solving process that really can facilitate these kinds of healthy behaviors. We also have some evidence that group process can be helpful, putting that positive peer pressure of a group where we really support the healthy behaviors. That can be helpful in addition to some of the other things we're talking about. And then there are some cases where we need more intensive psychological treatment, like cognitive behavioral therapy, for any comorbid mental health issues. And then I just want to conclude with a quick comment about the future of pediatric weight management. We have a good foundation right now in terms of the behavioral treatments for this condition, but there's clearly a lot of room for improvement, and we will need to do better to address this incredibly important issue, and an issue that is not easy to treat. And so just a couple of thoughts I have about what pediatric weight management will likely look like in the future, some areas for improvement. One is the increased use of technology, and the buzz term here that you hear a lot is mHealth, which refers to mobile health technologies, using real-time data collecting technologies to inform medical and behavioral care. So if providers had a way of seeing those self-monitoring data and providing feedback and structuring treatment based on those data, I think that's really the future of pediatric weight management. We also really have to do a better job of tailoring our treatments to the individual needs of individual kids, because we tend to take a one-size-fits-all kind of approach. And that works okay for the general recommendations, but different families and different children have unique challenges and unique obstacles, and we really need to tailor the level of our intervention better to those specific needs. And then finally, I strongly believe that the future of pediatric weight management is in an interdisciplinary team approach. This is something that requires a pediatrician and a psychologist, and often a nutritionist, and often a physical therapist, and teams that really work together at the different pieces of assessment and treatment implementation. And so I think those teams are really going to be the most effective way of treating this problem. And actually this webinar series does a nice job of thinking about those interdisciplinary issues and allows us to work together toward better treatment. So that's the end of the material that I have prepared, and I think we have some time for questions.
Great. Thank you so much, Dr. Nelson. We will now open the webinar up to questions. If you have them, again, you can type your questions in the chat or question section at the right of your screen, or you can press the raise your hand button, and we can unmute your line. So we'll take just a couple minutes here and let people get their questions in.
Dr. Nelson, this is Carla Lester. Thank you for your talk. It was great. I was in attendance at your symposium, and so one of the things you said there was, and you may have covered this a bit too, was talking about the importance of addressing barriers. And that for me, I mean, maybe that seems intuitive to you, but just the fact that to let medical professionals know that children already know and families typically know the importance of physical activity, the importance of eating healthy. I mean, they need some education on those things, obviously, but yet harboring on that and constantly, you know, kind of focusing on that rather than addressing the barriers, really, their true barriers isn't going to get us anywhere. So I didn't know if you had any comments about that.
You're absolutely right. Most of our patients have some idea of what they need to do. And often the thing that we need to focus on is not convincing them that physical activity or vegetables are important or things that they should be doing, but actually helping them to get there, helping them to overcome the but in that. Yes, I want to be physically active, but this gets in the way. Or yes, I want to eat fruits and vegetables, but they're really expensive. And actually some research that I did a little while ago found that it wasn't the positive attitudes toward physical activity that predicted whether a child was actually active. Most kids recognize that physical activity will make them healthier and stronger and all these wonderful things. The thing that predicts their activity is the negative attitudes, the obstacles that they face. And actually, you know, if physical activity is uncomfortable, if it's painful, if it's something they're made fun of when they engage in it, those are things that we need to work with them around. How do we pursue healthy behaviors even though it's not easy? And those are things that a medical provider and a behavioral provider can really spend some time with a family problem solving. And often there are solutions out there for motivated families, and we can be really successful.
Great. One of the things, too, that I think physicians particularly worry about is causing harm. And I know you talk about being, you know, clear and concise and sensitive with it, but, you know, we don't want to focus on so much about obesity, but I mean, do you have any tips for when you're talking to them about BMI percentile, their weight status category, you know, how you can deliver those messages in clear, concise, and sensitive ways?
Yeah, I think we have to be really honest and direct, but also to recognize that it can be difficult to manage a child's behavior and to manage a child's weight, and to be empathic in listening to the obstacles and really to form an alliance about how we go about tackling those problems. I think when we have a tone where we blame the family, even though that there may be causes there, that's where we get into trouble. But if we focus on the things that we can do and on empowering families to be able to problem solve and take steps toward these really positive, healthy activities, I think that's the way to go. And I think in the long run, that keeps the focus off of weight so much and puts it back on just healthy things that you should be doing. Being physically active has a number of benefits beyond just weight management, and the same thing with healthy eating. So really the focus on the healthy and developing healthy habits is really where I try to put my focus.
Okay.
I think that'll wrap it up for questions at this time. If anyone thinks of anything, in the meantime, they can certainly contact or send their questions to me, and we'll see if we can get a response still from Dr. Nelson. It's PAMIS@nebmed.org. You should receive a link here via email in about an hour that will have the post-test and evaluation link so that you can receive your continuing education credits. And again, here's the website where the webinar will be, and all previous webinars, I guess, are also listed. on the Nebraska Medical Association's Childhood Obesity Prevention Project website, www.nedmed.org/COPP.ASPX. And you can view any of the previous 5 webinars, and this webinar will also be available within a couple of weeks on that website. To remind you again about the Foster Healthy Weight and Youth resources, and you can email Holly Dingan here at the state, and she can get some of those out to you if you haven't seen those. And we want to thank everybody for taking the time, and thank you, Dr. Nelson, for a fantastic presentation. And we look forward to continuing this webinar series into 2012. 2011 focused on the comorbidities of childhood obesity. Our 2012 series will focus on prevention and focusing on community and whatnot. So we're working on getting some great speakers lined up for that. So stay tuned. If you're on that listserv, you will receive more information about the series for 2012. So thank you all and have a good afternoon.